Hello, everyone. My name is Biagio Ricciuti. I'm one of the thoracic medical oncologists at Dana-Farber Cancer Institute. And I was invited to share some highlights from our recent publication in VJOncology, where we explore the role of neoadjuvant chemoimmunotherapy in a particularly challenging patient populations, a patient with borderline resectable or unresectable stage 3 non-small cell lung cancer. While concurrent chemoradiation therapy followed by consolidation with durvalumab, a PD-L1 inhibitor, is today the standard of care for non-resectable stage 3 non-small cell lung cancer, the cure rate with this approach is still very low. And patients with bulky T4 multistation and 2 and 3 disease, for example, those are often, if not always, considered non-operable. But the concept of using neoadjuvant chemotherapy plus immunotherapy to downstage these tumors and allow surgery is certainly gaining ground in our community. However, these high-risk patients have been either excluded or represented only a relatively small fraction of patients enrolled into pivotal clinical trials, such as CheckMate 816 or KEYNOTE-C71, for example, which focus on the larger population of patients with non-small cell lung cancer stage 2 to 3B. And so we did conduct this multi-center study where we involved 112 patients across different institutions, including Dana-Farber, Memorial Sloan Kettering Cancer Center, and Regina Elena Cancer Center in Rome. All patients included into this study had stage 3 non-small cell lung cancer with either T4 or N2 single or multistation disease or N3 nodal involvement. All these patients received neoadjuvant platinum-based chemotherapy in combination with PD-1 or PD-L1 inhibitors. And then we assessed the surgical resection rate, pathologic response, and survival outcomes. And we also did some correlative analysis to identify biomarkers of immunotherapy efficacy in this specific setting. Of the 112 patients that were included into this study, 75% underwent a successful surgical resection, and 96% of these had R0 resections. The pathologic complete response was 29%, and 42.2% of patients achieved a major pathologic response. These data overall align with the same rates of PCR and MPR we have seen in randomized clinical trials looking at stage 2 to 3B non-small cell lung cancer in general. Event-free survival was approaching 50 months in this study, although the median follow-up was relatively short. But importantly, patients who achieved a complete pathologic response had a significant improvement in event-free survival and overall survival compared to patients who did not achieve a complete pathologic response, with very few events in patients who did achieve a PCR. Even among patients with multistation N2 disease or N3 disease, pathologic response rate were very similar or comparable to those patients who had a single station N2 disease, for example. In terms of clinical and pathologic and genomic biomarkers of response, we did confirm that current smokers had the highest pathologic complete response rate, 44%, compared to former smoker or never smokers, for example. PD-L1 expression continues to be a strong predictive biomarker even in this setting. PCR rates were observed in 50% of patients with high PD-L1 expression levels, 25% in those with a PD-L1, which was intermediate, 1 to 49%, and was only 7.4% in patients who did not express PD-L1 on their tumor. Importantly, combining PD-L1 expression and tumor mutational burden allowed us to identify patients with the greatest likelihood of achieving a PCR, and this data suggests that we should be using these biomarkers to identify these very high-risk patients that may be eligible for neoadjuvant or perioperative chemoimmunotherapy approaches who have stage 3 that's borderline resectable or potentially by criteria non-resectable. Importantly, we also look at co-mutation patterns. Specifically, we focus on KRAS STK11, KRAS KEAP1 co-mutations. We do know that this mutation can confer resistance to immunotherapy. And in fact, in this study, we did see that patients with co-mutations in KRAS STK11 or KRAS KEAP1 had a complete pathologic response rate of 0%. So no PCR were observed, unfortunately, in patients with this genomic profiling. This is also helpful because we are currently starting to test these mutations in the clinic, and we should be using this information to identify patients who should not be candidate for neoadjuvant or perioperative approaches, especially if they have high-risk features such as a borderline resectable T4, N2, or N3 non-small cell lung cancer. Of course, this was a retrospective study with several biases. This was a highly selected patient population. The sample size for genomic analysis was also modest, And while surgical decision was made in multidisciplinary discussions, resectability, of course, criteria can vary across institutions and possible countries. That said, this remains the largest data set to date, focusing specifically on high-risk stage 3 non-small cell lung cancer patients who have either T4 or N2 multistation or N3 disease who receive neoadjuvant chemoimmunotherapy. These findings overall supported this strategy as a potential option for patients with stage 3 non-small cell lung cancer. And particularly, these data support ongoing studies that are prospective in nature that are exploring specifically perioperative or neoadjuvant chemoimmunotherapy approaches for this patient population.